The experience of physicians during the current COVID pandemic is not one size fits all. The experience of a physician in rural Oklahoma, for example, is likely very different from that of a physician at the epicenter of the outbreak in New York City. The number of COVID positive patients a physician sees, how much PPE they and their team have to protect themselves, the number of available beds in their hospital, the types of symptoms and the degree of illness in the patient population they see, all of those things can look very different and make for different types of challenges. And yet it's so important that physicians from all parts of the country get the same information and training so that no matter where people get sick, they can be assured of getting the best possible care. Which is why I was so interested in talking with Dr. Camilla Sasson. Dr. Sasson is an emergency room physician and PhD researcher in Denver, Colorado, with an expertise in ventilator management. However, I interviewed her in New York City while she was spending several weeks volunteering to relieve overworked doctors and train her colleagues there on ventilators. But what made our discussion so fascinating was that what was important to her was not the medical knowledge and training she was bringing to the doctors in New York, but what she was bringing back. The knowledge and expertise she gained by being there in the epicenter of this disease and the experiences of being in hospitals with these incredibly sick patients that were completely overwhelmed by COVID. It was these experiences that she felt were so essential in shaping her personal role in this crisis as a caregiver and as an expert and mentor to other physicians at home and around the country. Because that was how she felt she and her colleagues were going to make a real impact. She's insightful, thoughtful, hopeful, curious, empathetic, authentic, humble, you name it. I hope that she is also an inspiration to everyone who watches this in difficult times. So without further ado, my conversation with Camilla Sasson. Welcome, Dr. Sasson. Thank you for joining me today.
Thanks for having me.
So I wanted to start off maybe just having you talk to me a little bit about how your experiences with coronavirus and how it changed life in the emergency department. How have things changed for the teams that are working there?
Well, I think I actually practice in Denver, Colorado. And
right.
So for us there, we have seen a huge decrease in our volumes. So 50, 60% of our patient volumes are down. And of the folks that are coming into the hospital, they're really, really sick. And so, I think that might be maybe some better triage that we're doing so that only those folks who meet criteria, if you will, are coming to the emergency department. There's also probably folks that aren't coming to the emergency department who should be coming. So our heart attacks and our strokes have not gone away. They just aren't coming to see us right now. And then I think what we're seeing here in New York City is we're now on the other side of the curve here. So, we had a huge peak, and actually I got here just a few days after the peak occurred, and we're starting to see the volumes go down, and they're very similar now to what we are seeing in Colorado. So 50, 60% drops in the normal pre-COVID volumes. And so I think that's something that most people are trying to still grapple with, because everyone says, there's still people dying. There's still obviously a huge, epicenter, if you will, of COVID-19 in New York City. And I think the thing that's really hard to really wrap our brains around, especially as emergency department docs, is that many of those people have come in. Now, many of those patients are in the hospital either on chronic oxygen therapy or on the ventilator. And so this isn't a disease process where you come in, you get better in a couple of days. These are folks now who are in the hospital for weeks, even months, potentially. And I think that's very different than anything I've trained for personally as an emergency department doctor.
Right. Well, I mean, it has to be, was it surprising to you at first, the fact that you didn't have more people coming in to the emergency department? Or was that something that you anticipated? Because it seemed to me like, I don't know, the natural inclination I would think would be to think that more people would be getting sick, more people would be calling 911, more people would be coming in, but that isn't what happened.
Yeah, I think, again, it's varied so much by where you are and at what point do you enter the healthcare system as a provider, right? So I think if you were to say in New York City, in certain parts of the city, so not actually everywhere in the city, but actually in certain neighborhoods in the city, their hospital system's completely overwhelmed. Then you go to other parts of the city in New York, or even if you go to Denver, Colorado, we're sitting back trying to figure out where is everybody? We don't understand. And I think a lot of that has to do with social distancing measures when cities and states and towns actually even started to do some of their shutdowns. And we know that when you do that, 2 to 3 weeks later, we see a huge drop in volumes. And I think that's what we're seeing right now here in New York City. I think a lot of us are thinking, especially for me in Colorado, we open our state back up April 26th. So what does that mean for us? What will that mean? Not April 27th, but more likely 2 weeks after
Right.
April 26th. What will that mean? And I think that's just something that's so hard for us to really try to plan for, prepare for. And we're all in just uncharted territory right now. And I think that's really disconcerting to a lot of us because we're all kind of used to just knowing we know what to do, right? Especially in the ER, we're good at doing that. And this is just different.
Yeah, it has to be like that. That delay is really difficult for us all, I think, to sort of be like, well, we know what's going on right now, but anticipating what that's going to mean in 2 weeks is a totally different story.
And how do you staff for it? How do you make sure that your hospitals have capacity for it? How do you still allow people to do the things that they still need to do, right? So how do you get people back into the workforce that have to be there? But at the same time, how do you also make sure that some of those surgeries that people have been putting off for months now, they still need to get done? And so again, I think everyone feels very uncertain because in many ways we're in a holding pattern, but we're chasing something that's kind of has a 2 week lag time. It's just hard to kind of wrap your head around.
And also a lot of variables, right? I mean, variables that we can't necessarily
Mm-hmm.
control. I was just reading an article in the New York Times yesterday about the fact that there are five, different, they compared 5 different models of what might happen over the next month, and they all kind of disagree with each other. And they're all also based on the fact that we maintain our current levels of social distancing, which a lot of places are talking about not doing. So what does that mean if Colorado does, but Ohio doesn't, and New York, you know what I mean? All of these things like make a huge difference. So it's very hard, I imagine.
Well, it's funny as a researcher, you always sort of say, like, if I have this variable constant, what happens if I change this variable, right? And I
Right.
think we like to think of it in a one-to-one relationship. And here we're sort of thinking of one to many. And then you add on more layers and more layers. And I think those models are helpful. But again, I think, there's been a lot of controversy about which model do you use. And I think the reason we can't really sort of hang our hat on any of these is that one small action here has a huge impact here, but then you've also got all these other confounders that are also going to change your model. So it's really challenging.
What you said that a lot of the time the patients that you are seeing in the emergency department are much more sick than what you normally might be seeing. So tell me about like what that means. What kind of patients are you seeing? What sort of differences are we talking about?
Well, I think what we've seen is that we've seen a move towards telemedicine, right? So we're seeing patients who are now calling ahead. They're having conversations with different types of healthcare professionals first to say, here are my symptoms, here are my comorbid conditions that I have. What are some of the, what should I do, right? Should I go to see you? Should I do a video visit? Should I do a telephone visit? Should I do an urgent care visit? And then at that point, we escalate to the emergency department potentially. And so I think what we're seeing is just maybe a better allocation of resources so that the people who are coming to the emergency department are the sickest folks. Now that's in a system that isn't completely stressed, right? So in Colorado, we have that sort of opportunity to do that very, kind of systematic approach. What we saw in New York City is that people didn't necessarily have the time or they all were sick so quickly. And because we don't necessarily know who's going to get sick or how quickly they're going to get sick, we just know that sometimes people, especially with COVID-19, will come in on 5 liters of nasal cannula and an hour later, they're intubated. And that crash can happen quickly and we can't really predict it right now. And we don't really know for sure what would say you're the one that's most likely to decompensate quickly. And so I think that in many ways is also the reason that when people do come in, it's sort of this fine balance of, are they going to do okay? And then 7 to 10 days into their clinical course, they have this potential cytokine release. Now, these are all ideas. Nobody knows for sure. And then they have this precipitous drop where they stop breathing. And so again, when they're coming to us, what time course are they in? Where are they in their disease process? And how quickly do we have time to intervene? And we're seeing that, it's more and more important now to keep people off the ventilator. So do everything you possibly can to stay off of that ventilation. And I
Yeah,
think that's where, yeah, that's
go
changing
ahead. No.
things too, for sure. Oh, no, I was going to say, I think that's been a big change for me as a clinician, because there's this whole concern for aerosol generating procedures. And so you're balancing the risk to the provider as well as to the patient in terms of providing positive pressure or trying to temporize before the ventilator. But because the ventilator mortality is so high, we're now kind of taking a step back and saying, gosh, we got to do these things first, even if there's potential risk to the providers. And I think that's a really tough thing for me to understand, especially coming from Colorado, where we weren't overwhelmed. And then you get to New York City, now it's become a standard of care to try all those things.
So tell me a little bit about that in terms of, the things that we have now, the procedures that you now have to put in place that are different than what we had to do before. I mean, obviously before there wasn't this great risk with any aerosolizing procedure. So now we have to totally change our thinking as physicians and, emergency responders of should I treat this patient and how should I treat this patient and balance that safety of the healthcare provider against the benefit that you're going to provide the patient. So maybe you can speak to that a little bit.
I think that's the $1 million question. I mean, I really do. I think that's really the hardest one to answer. And I think it depends a little bit about where you are on that curve, right, that we talk about of patient volume. If you get to the point where they did in New York City and everybody who came in had a COVID-related complaint, well, their emergency department became the COVID unit, right? In Denver, Colorado, where the vast majority of patients who were coming in were not COVID positive or did not have those types of symptoms, then we were able to do some of those negative pressure rooms. We were able to do more of those kind of, all of the steps that we've been hearing about from the CDC. And I think, again, when you get to the point where, you're overwhelmed, your system is at capacity, and you've got to provide a very quick intervention, or somebody's going to end up on a ventilator, you have to make those critical decisions that sometimes are balancing patient outcomes with provider risk. It's a really difficult place to be, and one I don't think we've ever been in before.
I mean, the American Heart Association and a number of different organizations, recently put out some new guidelines to kind of help you guys make those decisions on, what to do and how to do it. Do you feel safe? Do you feel like those things are helpful in, making sure that at least you're protected as much as you can be, or making the best out of the worst situation?
Yeah, I think it's been really important to come to some level of consensus. And so we just released our interim guidance for ACLS, BLS, and pediatric advanced life support. And I think the reason that it was so important, especially when it was released, which is just a few weeks ago, was that we brought together 8 different organizations, 40 plus volunteers, in resuscitation, in airway management, in ventilation, EMS, trying to bring all of these folks together to come to some type of guidance that could then help just to give people an idea of where to start. Because I think that's been the most challenging thing, is that the guidance is changing so quickly. The data is evolving so quickly. It feels like what I learned yesterday is obsolete by tomorrow. And so I think, bringing all those folks together, doing it in rapid fashion, with the idea that we are going to continually have to evolve this guidance. This isn't the first thing you're ever going to get, and it's not going to be the last thing you're ever going to get from us. And that's because as we take care of more patients, we're learning more about what works, what doesn't work. And so we, as an organization at the American Heart Association, in collaboration with all of these other associations, have to be willing to say, this is what the guidance is today, and it may change tomorrow. So bear with us, but what we're going to do is we're going to try to stay on that leading edge so that our clinicians know what to do to keep them safe and to get the best outcomes possible for their patients. And it's hard. It's different. We are used to sort of releasing guidelines and saying, here they are, enjoy them for the next 2 or 3 years.
Right.
Now we're saying, here they are, enjoy them for the next 2 weeks, possibly,
right.
So it's hard.
Is that part of what drove you to decide to leave Colorado and go to New York? I mean, obviously, you must have some expertise in this area of, managing patients on ventilators. So, I imagine there are tons of physicians there that this is not what they do every day, and they need some help. So.
Yeah, and my role here is truly as a clinician at a field hospital, right? And so I'm here to learn. I'm here to learn from my patients. I'm here to learn from my colleagues. And I'm here to honestly gather information because everything is changing so quickly and there's not a critical mass of patients except here in New York City. And so my role, as I see it, is both to take care of my patients and to be that person that can help them get through their disease course and their disease process. But more importantly, to spend some time and to really think through, hey, look, what are some of the things that are happening here in the epicenter that we then need to think about as an organization and bring up to our organizational partners to make sure our workforce is adequately trained, educated, and understands what they're dealing with, because the vast majority of us don't know. And I think that's the hardest part as a clinician. I'm used to knowing the answer. I can read about it. I can, find the answer. And I think we're learning as we go. And so I felt really compelled to go to the epicenter so that I could live it, breathe it, understand it, study it. I'm a researcher. I have a PhD in research, and that's my role right now, is to just take that step back and say, how do we translate this information that's very critical as an organization, as an association that leads resuscitation training throughout the world? How do we take that and put that into format that can be used rapidly as guidance for healthcare professionals to save the most lives?
So in a way, it's not so much what you're like contributing there, but what you're getting out of it so that you can share that with the rest of the medical community.
I am so thankful to the city of New York for letting me be here. I really am. I am thankful because I've seen patients who, in my mind, I didn't think could survive COVID-19, who are going home right now. And those are the ones that, give me hope that we can do this. We can take care of this disease process. And I think most importantly, we have to be willing to say, look, we don't know the answers today, but what we're going to do is we're going to work with the best available knowledge. It's not even data, it's knowledge, and see how we can rapidly improve the care of COVID-19 patients. And so just very thankful that the colleagues that I've made out here, the clinicians that I've gotten to know, are willing to share that information, because we've got a group of professionals from all over the country that are here, and we're all going to take those pieces of knowledge back to our communities and make a huge impact. And it's all because of the folks here in New York City. And I feel so thankful to even just be able to be a part of this.
Is there any one thing for you, a moment, an experience, a piece of knowledge that surprised you, that has really struck you and like that you're gonna sort of carry with you and take back?
I think as many clinicians right now are feeling, I came into this anxious, afraid, panicked, completely overwhelmed by the amount of information I didn't have about how to treat COVID-19. And I feel like when I leave in a month from now, that I'm going to feel like I have a little better understanding, but more importantly, I have hope. And that's something that I have not had, I'll be honest, for months now. And so just thinking about that, bringing that hope back with me, bringing that patient who was older, who is now going to be going back to their family, that's what's going to get me through those really, really tough days in Colorado, is just knowing that, yes, you know what, we can do this as long as we use our resources wisely, as long as we make sure that we coordinate care and that we don't let one hospital system get overwhelmed, or we make sure that one neighborhood doesn't have a huge cluster and we don't spread out all of those patients. Those are the lessons that I think are going to save lives, and not just in Colorado and Denver, literally all over the world.
Yeah, I think it's going to be fascinating to watch this evolve over time. And it is kind of a strange feeling in a way. I think you're sort of conveying this sentiment that from a research perspective, in a dispassionate way, there's like something really fascinating to see how this like plays out like piece by piece and how one thing affects another thing. And yet it's also like so hard because against that is this strong human element of this is not just, something you're watching playing out. It's not a movie. It's someone's life, many thousands of people's lives.
Yeah.
I don't know.
Well, and the actions that we have today make an impact on what happens to us in 2 to 3 weeks from now. Like just trying to grasp that concept, I think has been so hard for me personally. I think so many of us live in the moment, right? And you're like, oh my gosh, like what I did 2 weeks ago is going to matter. What? So, I think that's been a big, kind of challenge to my normal, kind of my notions of what this is, because again, I got here when I was watching the news and everybody, there's a huge surge and it was relatively quiet. And that's because we put those social distancing measures into place 2 weeks ago. So, again, it's such a totally different perspective to have to look at things from. And then I think at the end of the day, it's about patience, and like actual patience with a C, not the actual patients that we take care of, but
right.
people
Patience.
having, like people having patience.
Yeah.
And I think that's the hardest part, is that you cannot manage COVID-19 and the surge of infections that we will have unless you are willing to wait your turn, unless you're willing to be patient yourself, and you're willing to listen to people who are really, really smart, much smarter than any of us are. And that's really hard to do. Even as a doctor, I think I wanted to come here and have all the answers, and I realized I've got maybe about a quarter right now. And so I think just taking that moment to be humble and to say, look, you know what, I'm going to do this because not only is it going to make me better, is it going to save my family, my friends, but it's actually going to allow my healthcare systems and my hospitals to be able to take care of me or my family member when we get sick. I think that's a very different thing that we've ever had to do before as a community and as a global population.
As a society, yes, it's clearly very challenging still for many of us. There's like a lot of resistance
Yes, it is.
against us. That's still at the moment,
Yeah.
and it will be interesting to see whether or not we can all hold out.
People can do it.
Yeah, if people can do it.
And you're balancing this, like, it's so funny because you're balancing public health with how do I eat tonight, right? And there's that instant sort of need, there's the instant, it's not even instant gratification, it's basic survival.
Right.
And you're trying to balance that with the greater good. And I think to be able to do that and to be able to think through both of those things is really hard, especially if you're trying to figure out how are you going to pay your rent.
Right. I think it goes against our human nature in a way. Like, and by say that, I think it goes against our human nature in terms of we're not necessarily creatures that are capable. Well, I shouldn't say capable, but that we're not naturally designed to think that far ahead, right? To plan our existence 2 or 3 weeks out. I mean, if as a physician, right, if you were to tell someone, let's just say, okay, it's fine, these bananas, they're really going to be bad for you. So like you can eat it now and like you'll feel fine for a while, but 3 weeks from now, like this really bad thing might happen, right? How well is that going to go over? Like not so well. Like I think patients would have a really hard time doing that because they'd be like, well, but I feel fine. Like nothing happened. I ate it. Like, and I think it's sort of the same concept of like, we do these things now and we say, look, it's fine. Like, but it's not.
See, and you can't see it, right? It's this, you're fighting. I mean, I think Dr. Fauci said it really well. You're fighting an invisible ghost, right? It's a ghost. You're fighting this thing that isn't palpable. It's not tangible. And for me, actually going to New York City was to fight the ghost of COVID-19 in many ways, because for me, it felt very, very tangential. It felt very like I don't understand it. I can't even visualize it. I can't figure it out. And so being here was really for me trying to figure out what is the ghost? Who is the ghost? How does it work? How does it function? And so I'm fortunate in the sense that I can do that, and I can kind of take a step back as a researcher and say, what does this mean? What is this ghost trying to say? But I think for most people, they're not going to feel impacted until somebody they love is impacted. And then it becomes a real thing, a real entity. And it's hard for people to know that until they feel it or see it. And it's palpable. And so, but as a public health community, if we wait until it's palpable and tangible, then we've waited too long. Yeah. So it's hard. I mean,
have you actually seen like large wards of COVID-19 patients? Like, have you been in there, like where you walk in and there's just all these extraordinarily sick people?
Yeah, I mean, the hospitals are, the emergency departments are eerily quiet because all the patients are now in the cafeteria on ventilators, right? And waiting rooms that have been turned into COVID wards. And, you go into a hospital in New York City and say, show me the non-COVID ward. And they look at you like, what? huh? What
There
non-COVID
is no,
ward?
yeah.
There isn't one. Yeah, that, everybody has COVID-19. Even the person who comes in with the ankle fracture has COVID-19. So again, I think it's just this complete shift in mind frame, mindset, and then ultimately just really being very cognizant of the fact that we don't have all the answers. We're operating in an opinion-rich, data-free zone, and we likely will be until we have some real data collection that happens at a much larger scale than most people are comfortable with. And I think that's a piece of the story that people haven't really covered as much, which is having one hospital system do a case series of 50 patients is not enough. I mean, we're looking at population level data that gets translated into emergency department data that then gets translated into hospital level data. And that's something that we historically have been terrible at.
Yes, we are terrible at that. I mean, like just collecting
Yes.
healthcare data that we share amongst each other. It's just we are not designed like as a society to do that correctly. But you're right, it's suddenly super important. And that is a good story, actually. Thank you. I will think about that
Yeah.
because you're right. I
Yeah.
mean, for the first time, we can see a really tangible like result of if we have all this data and we can compile it and we can put it together, like how incredibly valuable that is. And
Well,
maybe
and
then
and not and and
take
not
it
wait a
with us to
year.
extrapolate how incredibly valuable it will be to do that for other things.
Well, and the Heart Association has started its own registry specifically for hospitals, at least, to start looking at that, looking at those patients who are in the hospital who have COVID-19 and how that affects them from a cardiovascular disease standpoint. Mix that in with EMS data from public health department data.
Right.
And you could start to see how these layers come out. And I think the thing that is the biggest caveat to all of this is that if we wait 6 months, we've waited too long.
Yeah.
We need to be looking at this data week by week and then rapidly improving, just like we would do rapid improvement, quality improvement for everything else in the hospital. We have to do that at a global level, at a population health level, and be willing to say, this is what worked this week, and we have to change course. And that's really, really difficult because there's a lot of inertia behind not changing course. So
Well,
I think those are all things that we have to do. Yeah.
I was thinking too with the data is that, I mean, it's also really important that everyone is collecting the same data in the same way. Because I was reading another article where they were talking about the fact that, you know, you couldn't compare certain statistics from certain hospitals because they weren't like using the same definition, right? Or so people didn't, the same things like were written didn't mean the same things when you compared them side by side. And that's going to be the kind of thing that's extraordinarily important, like going forward. We have to have all of our data be the same data, like mean the same thing in order to have a meaningful comparison.
Well, and case definition matters, especially in the setting of a pandemic, right? Because if you don't define COVID-19 the same way I do, with the lack of available testing, there's oftentimes not a confirmatory sample, right? It's based on suspected COVID-19 infection. So what does that mean? What does it mean if you die at home? Do you go back and do contact tracing to figure out if somebody else had COVID-19? I mean, again, those are all things that are going to make a huge impact. And we don't have a good idea what the denominator is. And until we get to a better system of data collection, we will never truly understand the impact on our communities. And there's no way we can predict that impact unless we have a good idea of what happened before. Sorry, I get very passionate about data in case you can't tell.
No,
So,
I love data too, actually. I actually keep my own state's data. I go to the site every single day and I keep a spreadsheet of it because
yes.
I was annoyed that I couldn't compare what happened last week or the week before. They're only giving me today's data. So I'm like, well, I actually had been writing a few of them down. So I was able to go back and I have from the very start, like every single thing. But then I realized there was pieces I had not put in. Like I didn't put in all the deaths. I just wanted to know what the numbers were. And like, I don't know. Anyway, I like it.
But it just tells you that there's such a dearth of data, right?
Yeah.
And if we're going to solve this crisis, the way that you solve it is by looking at your information, making reasonable, rational decisions based on data. And right now that's not happening in many locations, at least. So,
I know you have to go, but I do have just one quick last question. And that is,
yeah.
what kind of testing are they currently doing in New York? And what kind of testing?
It's highly variable. Yeah.
In
highly,
Colorado.
highly, yeah. I mean, it's so highly variable system by system, hospital by hospital. Primarily right now is if you're being admitted, that you'll get the test done. So anyone who's getting discharged home is not getting testing done. And that's the same for both New York City as well as Colorado. And that's just because we don't have enough tests. I mean, I think we would all love to test every single person out there, but you have to sort of pick and choose who gets the test. And I've personally taken care of patients who've got COVID lung findings and have a negative test. So 30%, 30% false negative. And that's a huge deal, right? So even if you have it, what does the test really mean if 1 out of every 3 times it's wrong?
Well, I mean, and I was wondering too, just on the flip side, because, you said you have somebody who comes in with, an ankle fracture and they actually are COVID positive. Or like, as you were saying, you have these patients who are coming into your ER in Colorado and they're not having COVID symptoms. Yet I have already spoken with a couple of, different doctors in various specialties, cardiology, neurology, that are saying sometimes patients come in with cardiac or neurologic symptoms, no lung symptoms at all. And like, they actually are COVID positive. So it's not,
I can't tell you how many times I've seen that already. They come in with nausea, vomiting, diarrhea, and they've got COVID. Right. I mean, it's just one of those things, and it, a rash, they've got COVID. I mean, it manifests in so many different ways, and respiratory is the one that we think about. Fever is what we think about, but there's so many people who don't have any of those symptoms, or they have such varying degrees of it that they don't even realize they had symptoms a week ago, and they've been wandering around, infecting other people in their household. And so I think, again, that's what makes it so difficult to contain.
Yeah. So we really do need a test that is much more accurate and
fast.
I guess, and probably sensitive as well, right? To make sure that we have both, eliminated positive, false positives and false negatives.
Well, and I think the big thing too for us, at least in Colorado, is that it can take a week to get a test back for a disease process in which you've got 7 days to basically go around and infect everybody else who you've been in contact with. And we know you're not going to see symptoms for another week, right? The people that you've infected, that's devastating.
Right.
And so, again, it's got to be a rapid fire. I can do a flu swab. I get my flu test, my rapid flu back in 10 minutes. I mean, that's where we need to be, in my humble opinion.
Yes, no, that would be great. I think that I've heard that they are developing rapid tests. I don't know how accurate, again, they are, but.
Well, and I think if we don't take into account the fact that we need enough swabs and we need enough reagents, I mean, I think that's the untold story, is that everyone has focused so much on the testing, capabilities, but not the supplies. And I can tell you, in Colorado, we had that issue where it didn't really matter how fast the test was. We didn't have any swabs.
Oh, jeez. That has to be the most frustrating thing in the world, right? I mean, how can you just what am I supposed to do?
There's a lot of things that have been very frustrating. So, again, you say, and that's where we've come up with these suspected COVID definitions, case definitions, right? Where it's, hey, look, you've got the symptoms, or I've got enough clinical suspicion to think you do, then I'm going to tell you to self-isolate until your symptoms are gone. And then we will, kind of move forward from there. So, I think, again, and this goes back to the whole idea of even the flu, right? Even with the flu, we do the same thing, where I don't test every single person who comes into the emergency department. But what I do say is, look, I think you have the signs and symptoms of the flu. Their management's not going to change whether or not you have a positive test. At the end of the day, you still need to do X, Y, and Z. And I think we've been treating it in that same way, which is, look, we don't have the ability to test everybody. And I know you want the answer, but at the end of the day, do what we know works. And if you are getting sicker, come back immediately, because we don't have a huge interval of time in which you're doing fine and then you crash. And so I think that's where we're trying to really tease out that sort of high risk group, and how do we tell them when is the right time to show up in the emergency department, because that's the key sweet spot that I think we still need some more information about.
Well, thank you so much for your time. I know we've run over.
Sorry, I get very passionate
so interesting
about this
to talk to you. I love it. So I hope that maybe you and I could have a chance to check in again in a few weeks or a month or two and see how things have changed. It might be really interesting.
Yeah, I'll tell you. I don't know. I have no idea. It's fascinating every single day. I mean, it truly is. So, but yeah, no, I'd love to chat again. And Monica has all my contact info, and I appreciate you guys just doing the story.
All right. Thank you so much.
All right. Thanks. Have a great day. I'm going to go run back.
All right, bye.
Okay. All right. Take care. Bye.